So now let's turn to our guest speaker for today, Dr. Jack Hahn. Dr. Hahn is a true pioneer. He's been placing and restoring implants for over 50 years. He's received numerous honors, including the Lifetime Achievement Award from the AID, and more recently, the Isaiah Liu Award from the AID. His lecture today is immediate implant placement after extraction, a procedure that he developed and has perfected over the years. But of course, I know Jack, and his lecture will probably cover a wide area of topics in implant dentistry, and you'll get a lot out of it. So Jack, thanks so much for coming back. And I'm going to turn this over to you right now.
Okay, Neil, thank you.
Slides are up and they look great.
To share again. This is something I really like to do, is to share a lot of our experiences that we've learned over the years, either through colleagues, other clinicians, or our own experiences. So this first picture here that you see is part of a textbook that I co-authored with 3 colleagues, and I did the immediate extraction from single tooth to full arch chapter in the book. When I started in implant dentistry a long time ago, everything was immediate loaded. The implants were mostly blade type implants that had the abutment as part of the implant. They were one piece. So everything was placed immediate load. And what we were doing is solving problems of edentulosum, either eliminating partials or dentures. So single tooth replacements really didn't come into real popularity until the early 80s, when the Brennemark system became more prevalent. Okay, so we see an implant, a tapered implant, which is more user-friendly, again, for immediate replacements, especially in the aesthetic zone. We see an implant that has a good thread pattern, tapered, so we can have a longer, wider implant, an anatomically constricted area. And then with the modern materials we have today, we have zirconia abutments. It's kind of soft tissue, and zirconium crowns. So we can, again, achieve optimum aesthetics and function. So things that I've been involved with over the number of years, I conceived the Stereos implant in 1986. And one thing, if you notice, that it had a machine collar. And the reason that was my idea, because if you look at natural teeth that have calculus, and if it's left, soft tissue becomes inflamed, becomes red. And if it's left long enough, it starts to lose bone. And so I figured that an implant is going to be similar. So we want to be able to have safety before it got into the rough surface or the thread. So that was the idea. And this held up for over 40 years of this concept, when they went to taking implants, rough surfaces, all the way to the top. Then we started seeing peri-implantitis. So the couple of instruments you see above, the magenta and the gold, those are osteotomes. And those are used to compact bone, expand bone, and bump inferior floor of the sinus, which you see in the middle upper slide, where we can bump the cortical plate, place some bone material, and then as we place the implant, it pushes that up so we can place, again, a wider implant. In the posterior, we want to do that because there's 4 times vertical load. Now, the slide, the Stereos blade, it says, I designed that because blades were still being used quite a bit in narrow ridges. And but my concept was to make it a 2-piece instead of a 1-piece. So if you wanted to do grafting and not to do an immediate load, you can do it. And then on the right, you see the latest that we designed was the Hahn implant, which has a more aggressive thread pattern and keeping the machine collar. Now, the one in the center replaced, that is not the original replace that I did. The original place I did had a 2 mm machine collar. And when they went to, when Noble Biocare took it over, then they made the rough collar to the top, and that's when we started seeing peri-implantitis. So if we look at natural teeth, this goes back to the concept of why a tapered implant. The widest portion is at the cervical. So when the patient functions, that force is transferred to the cervical area. And if we can minimize that force by having a wider prosthetic table, then we can preserve that crestal bone. So if we look at, this is published in the book, from my 20-year experience with immediate extraction, immediate load, it improved from parallel walled implants to where we got into the tapered. Now, some of this improvement could be that through experience, we learned something that we should do or should not do. So if we look at an X-ray of what we consider success, we see good integration between the threads. We see bone at the crest with peaks, which support papilla. It's a tapered implant. We can place a little longer and a little wider. So just to take care of some of the things we just talked about. So here we have some principles, and this slide will be up if you want to take a picture or copy it. Anyhow, so the implant should be longer than the tooth you're replacing by 1 to 2 millimeters. If you have more bone, then you can go longer. But I tell patients this is one aspect of medicine where we can improve what nature gave you. Implant should not contact the buccal or labial sacal wall at the time of placement, and that has to do with blood supply. A tooth gets its blood supply of the buccal bone from the periosteum and the periodontal ligament of the tooth. Well, an implant does not have a periodontal ligament, so we need to create some space for blood. So primary stability is the other thing that's very important. The common denominator of the cases that we did that lasted over 40 years is we had primary stability at the time of placement and able to maintain it. So I like to at least achieve 40 Newton centimeters when I'm placing the implant. So openings or gaps of more than 2 millimeters, you can take some graft material and tuck it under between the implant body and the buccal or labial plate. The provisional restoration should be out of occlusion if you're doing an immediate, and the patient needs to be compliant. You need to tell them, don't go bite into rib bones, or kind of stay away from it a little bit. So if we look at a natural tooth on a CT scan, you can see what I'm talking about. The labial plate is very thin. The lingual aspect is thicker, more dense. So if we move that trajectory, the angle, more to the palatal, that'll keep us away from the buccal. And again, we say the reason it works in a natural tooth is you have periosteum and periodontal ligament. So the first thing we're going to do when we take the tooth out, we're going to go in with a perio curette and feel the walls, the socket walls. If we see the tissue bulge like we see it here, then we know there's a hole. So we need to decide, how big is that hole? Is it more than 5-6 millimeters? Then I probably may flap so we can take care of the issue. We'll show some examples of that. So here, talking this through, we place the 2 millimeter twist drill to the apex, and then we slide it toward the palatal bone and go past that 1 to 2 millimeters longer. And if you have more bone, you can go longer. So if you're using an implant that does not have aggressive threads, then you may have to use a thread former against the palatal wall, because the palatal wall is thicker and denser. And if you don't and you self-tap, it'll walk the implant up against the buccal and you won't see it. until it's too late. Now, what's the reason for keeping it away from the buccal plate? Is if you fill the whole socket up with metal against the buccal plate, you'll get what we call an avascular necrosis. That means you're going to lose crestal bone and soft tissue, and you're going to have the metal collar or threads exposed. And if it's in the aesthetic area, the patient's not going to be happy. So we want to prevent that. If you look, here's a better illustration. So that we went up to the apex, slide it 2 to 3 millimeters palatal, and so you can keep it from contacting the buccal plate. Now, if it's just 2 millimeter gap, it fills with blood, that's good. It'll heal. You don't need graft material for that. What about angle? Angle determines the trajectory, will determine the prosthetics. So when I pick up that 2 millimeter twist drill, I'm thinking more about prosthetics, the angle, the position I want, because that's going to affect the restoration. And that's what people see. They don't know what implants are. They know what teeth are. So here's some examples. This is on the left, you see a hopeless tooth, class 3 mobility, but you see a lot of bone apical. So this is an ideal place for an implant. So we can start, and I like to use the tri-ends to check my position if we're not doing guided, and go as long as we can. And the closer we get in the maxilla, the closer we get to the inferior sinus wall, the more dense the bone becomes. So this will also increase primary stability. So you can see that we have in the X-ray good evidence of integration and support of the interproximal bone, which supports the soft tissue papilla. So we have a restoration. Is it an implant or is it a tooth? So this happens to be my daughter. She has a tendency for osteoporosis. So she felt something wiggling. She came into the office, and sure enough, number 5 was fractured. So we took an impression so I could send it to the lab, because I'm not going to do an immediate load. I'm not going to take the chance, but I do want to place an implant as long as possible. And here we're engaging the buttress between the nasal and maxillary sinus, which is going to increase primary stability even more. So we have a 16 millimeter 4.3 implant, which is a nice implant into good bone. And then the laboratory, after 4 months, we take a transfer, and the laboratory, which in my case is always Glidewell, will make the ceramic abutment, ceramic crown. And actually, we did this a year ago, and she was in the office 2 weeks ago, and we took this X-ray. So everything is maintained and looks good. So here's a patient that gives a history when he was a young playing baseball. He was hitting the mouth with a baseball. So it resulted in internal, external resorption. So we want to get these out. We don't want to leave them in forever, because they do lose bone. So my idea is we want to preserve as much of the crestal bone as we could, because this is in the front, and we want to be able to support papilla. So we're able to, again, get those ankylosed roots out. And you see a 3.5 by 16 and 4.3 by 13. So we have good support. Now we have 2 kits, a standard kit and a guided kit. Now I like to use the guided kit, not only for guided surgery, but you get into areas where you need a longer drill. If you use your standard handpiece or the standard drills, your handpiece will hit the adjacent teeth, and you can't get to the depth that you want. The guided drills are longer because the hubs are longer, so they fit into the guides. So in the posterior, where the patient can't open wide enough for a drill extension, these are very useful. So we have sizes all the way from a 3.0 that tapers to a 2.2 to a 7 that tapers to a 5. So try to solve all uses of the implant in all clinical situations. So here's an example in congenitally missing laterals of two 3.0 implants. So you can see with ceramic abutments. So one's a 13 and one's a 16. I try to use either 13 or 16 because for going narrower, I like to go longer. Again, we get into this primary stability. Now here's a patient, he's a high-profile sports announcer. He came into our office as a result of our website talking about the emergency implant. He fractured number 18. Now, generally on beginners, I don't teach this. I teach that grafting, grafted and go back 5-6 months later, you got a good ridge and be safe and place the implant. But here, he needed kind of instant gratification. So we placed the implant in a temporary abutment. We went right through the interseptal wall. Not only did we use the CT scan, which in posterior mandible has a tendency to maybe be 10% inaccurate. So as we go along, we can take our guide drill or guide pins or a drill and leave it in position and take an x-ray. So there it's in place, it's ready to be restored. And then this we did in 2014. So it was a custom abutment and ceramic crown. Today I would do this screw retained. I prefer to do screw retained. It's easier to maintain if you have to take it off. Now here's a patient that has a propensity for recurrent caries. So he has 7 previous implants in other areas. She came in the office with the 2 crowns in her hand, and we decided that in the long-term prognosis, it'd be better to take those 2 roots out and do 2 implants. And since she's had good luck with other implants, they become implant happy. She said, let's just do the implants. So I cemented the crowns on temporarily so I could take impression, send it to Glidewell so they can make a biotemp. And then when we got that back, we scheduled the surgery, removed the 2 teeth, placed the implants so that the top of the implant was 2 millimeters below the crest, because we want to make sure that we give the technician enough room for the margins of the abutments. So in preparing these temporary abutments in the mouth, we use a 558 crosscut Fisher burr with copious amounts of water and high speed. And after 4 months, we're ready to do the restoration. This is the day we did it with the 2 implants, 2 temporary abutments, and 4 months later, then we did the restoration, and we have 2 ceramic abutments and 2 Bruxer aesthetic crowns. So this is another patient, emergency implant, had previous implants on the premolars and called and said they broke this tooth and they're going on a cruise the next day. So I told them to come in. Again, we can do these at lunchtime a lot of times. It doesn't take a lot of time, careful extraction of the root. And then I could use her existing crown and refit it to the temporary abutment. So let me just show you about getting these roots out. Generally, when you see this, these roots are kind of mushy. So we got to get down so we can get a good purchase with a beveled elevator. So I use a 700 XXL burr, high speed. I couldn't be without this burr. So we start on the root and work your way to the alveolar process and create a channel, as you see on the right. And then we can take these elevators that are beveled or whatever and go on the mesial, distal, lingual, rotated, and sure enough, the root will pop out. So that's what we did with this lady. And then we're going to prepare the temporary abutment. And then I refit her existing crown, made sure it was out of occlusion. And we just loosened the tissue. So we just make sutures that tight to the abutment area. And then after 4 months, 3 months, we take our transfer. she didn't have really high aesthetic demands. And the lab provided a custom titanium abutment and rocks her crown. Now, the little blanching shows you that the gum is real healthy and tight. And after seated, that's Dr. Tarnow talks about the 7 to 11 minute blanch, and that'll go away. So here's a true emergency implant. This young lady is a pharmaceutical rep, had to call on doctors that afternoon and came in to the office for a re-cement and told her that's not going to work anymore. And she was kind of panic stricken until I told her what we could do to take the broken root out, prepare the site, place an implant, and use her existing crown as a temporary reformat, make sure it's out of occlusion. Again, since we just loosened the margin of the tissue, place 2 sutures tightly near the abutment and enhances papilla. And you can see in 10 days that suture removal, it looks pretty good. So this is the use of the drill extension. And this will show that the tooth itself, when you take it out, is going to probably wider than the implant you're going to place. Because again, what we used to think years ago was to fill that socket up with metal. And now we know you don't do that. So where is this 4.3 by 16 going to go? And it's going to be up against the mesial, distal, and palatal wall, and there'll be some room between the facial bone and the body of the implant. Now, this patient had a temporary flipper. Her cousin's a dentist, and he made it, being that this was broken. So you can see we're just tucking some cortical cancellous particulate bone in the gap. And then after 4 months, we had 3 millimeter healing abutment. So we can see that that's going to give the technician 2.5 to 3 millimeter margin for the abutment. So here's, again, the ceramic abutment. This is a abutment positioner that Glidewell provides back for me, and then the ceramic crown. Now, if you look at the gum line in 8 and 9, they're pretty much in harmony. That's what we're after. We don't want the gum on one to be way up and way down, because all patients have a high smile line the minute you see these. So what is the criteria for success? No pain, no mobility. If there's any slight mobility, it's a failure. So pain could be, maybe it's in hyperocclusion, maybe the occlusion can be adjusted. No soft tissue inflammation. That's the barometer. If it's red, bleeding, purple looking, there's a problem. So you need to probe that and take a periapical and see what's going on. How can we fix it? And the other is there should be no crustal bone loss more than 2 millimeters after 1 year in function. So again, we have to reevaluate. We spend a lot of time on occlusion when we see the case. So when about delayed replacement? Well, if there's insufficient bone loss or bone volume for primary stability, that's the thing. We need primary stability. In that case, we graft and place the implants 5-6 months later. We're going to also, in my opinion, do delayed placement if there's active infection or purulent exudate in the socket. So at that time, we're just going to clean it, put the patient on antibiotics for 10 days to 2 weeks, and go back in a week and do your procedure. We don't put graft material in infection area because of the pH is more aesthetic and it'll eat up the graft. So we want to play it on the safe side. So now, in order to teach and for my own benefit, I developed a classification for the socket walls. And class 1, that means all the walls are intact. No holes, no absence of labial plate, everything is good. And class 2 is there's a fenestration somewhere along the root area. and yet there's still crestal bone. And so you either have a whole apical or halfway through the in the labial or buccal bone. Class 3 is the buccal bone's gone. So for this, my own benefit for teaching, then we can go to examples. And again, we need an atraumatic extraction. We're going to go in with that curette and feel along the walls so we see what we got. So here's a case that's a full arch case. These teeth were totally wiped out, terminal teeth patient, but anyhow, all the walls were intact. So again, we can see we have a little gap between the buccal and the implant. So we have the implant in a good position. Now, this is an example of a class 2 where the fenestration is in the middle of the root and it's like a porthole. So we get this out. Again, this is some of the graft materials. I've just narrowed it down to a particulate mineralized cortical cancellous and a putty, which we call osteogen plug. And that has, it's a putty that has the granule component mixed into it and collagen. So we can hydrate this with saline that we get out of our unit, our drilling unit, and then place this after we prepare it. Now, we prepare the site as if that hole isn't there. Then afterwards, before we place the implant, we put our graft. So when we screw the implant in, it pushes the graft material through the window. So I call it socket seal. It seals it. So this is an example. You see crestal bone, the hole, and then bone apical. So this is still a good case. So if that hole was less in diameter, then I wouldn't flap. But here, this is 5-6 millimeters. So we put that in, and then we can take our putty and put over it. I'm not a membrane person. So here's where we put the particulate, and then we use the putty over it. And then this patient also had a flipper. Their dentist made it for him before they came to me because, as you saw, the tooth was totally fractured. So then after healing, which we can check, you see, again, the peaks of bone, supporting papilla, well integrated. I use closed tray and transfer, and laboratory then provides abutment and bruxer crown. And again, we're in harmony between the abutment, implant, and the adjacent teeth. So we can see that we did not lose any papilla. And so we have everything that's in harmony that the patient's not going to have a problem with. So if we cut papilla, that's a big problem. We don't want to do that. This is another example of a class 2. This is a wife of a dentist friend of ours. He didn't want to do this for himself, or he trusted me more than his referring guy that he sends for implants. So we took the tooth out. We prepared for 3.5 by 16. She had a fenestration, but it was a small amount that I could just use some particulate without making a flap, and then put a temporary abutment, took her crown and reformed it. And then after 3-4 months, took a transfer to the lab, provided the crown and the abutment. And her husband said, that's the best tooth she's got. Now, here's an example of class 3, where you don't see the buccal bones absent, but I want to keep those drills against the palatal aspect. So you can see that that thin bone in the front that's on the edges there, we're away from. So we can place the implant, again, holding it firmly against the palatal wall. And, excuse me. And then so that those threads bite into that wall, so we can obtain in this case, I think we got 45 Newton stability. So then we can place in abutments whatever we want. We can put our particulate and then the putty over it. Now, what about the incision? This is important. So we're going to make an oblique 45-degree angle incision and just go on the lingual aspect through the papilla. So stay to the palatal side on the papilla. And then we can reflect this and open it like the book. So I call it the book approach. So we have the 45 Newton stability on this case. And we can see that we put our particulate over the top and the putty over that. And you can see where we suture, just in between at the papilla area, interproximal, and then the oblique, so that the site is covered where we did the graft. So it keeps the graft in place. So we were able to, again, use this patient's existing crown. I shortened it a little bit, adjusted the occlusion. This patient came from Charleston, West Virginia, based again on their website, talking about the emergency implant. And her daughter was getting married and she refused to wear a flipper. So we were able to do this. And then after 5 months, I waited a little bit longer than we did our prosthetics, and she's happy. So here's a retired dentist that used to send us some patients. He called, he said, I'm going to Florida for the winter and I got something wiggling around, tooth wiggling. I said, come over at lunch. He did, came over. I said, well, this is gone. So he had absence of labial plate. So we went in longer than the tooth. You can see he had bone apical to the existing root. And we placed our graft material, our particulate, our putty. Now, if I have bone in the drills, in the quad spade drills, I'll scrape that in to a little cup of saline and mix that in there too. So that's what we did. Put a temporary abutment. I puttied just freehand. Temporary, wasn't pretty, but he didn't care. So then when he came back from Florida in the spring, then we just went through our prosthetic process, and we did a screw retain. A little purple thing on the gum is something I did. I was probing and I bruised it. So, but that went away. So here's a patient that was getting ortho to give space for a congenitally missing lateral. And what happened here is the dentist that placed the implant placed it way buccal. I don't know how they got it in that way, but this would never work. So what we did, I didn't place the implant, but I did the fix. So we did the flap. I took away the buccal bone and took the implant out and then prepared against the palatal wall, just like we showed in the previous pictures. And then we put some particulate and the putty over it. And then after healing, we were able to go in and restore this to form and function aesthetics. So what about the osteotomes? I'm going to be speaking at the Glidewell Symposium on the 24th of this month, and I'll be there. Time doesn't permit me to go in to every nuance of using osteotomes, but I'll be there. And if you come there, I'll be available. If you'd like, I'm doing a one-day hands-on course in Elizabeth, New Jersey on April 14th, and we can go into this more details. So these are generally in narrow ridges. So this is a bone caliper, and we have a needle on the buccal, and then we'll need to anesthetize the patient first. And we're going to just make a small flap where we can see the buccal lingual, because you're going to go in with a first drill, which is a 2 mm twist drill to the depth. Say you're doing a 13, you're going to go 13 if you're doing a 16 with that drill. And then you can take the 2.5 millimeter osteotome, and then you have to mount it. So these patients we sedate with oral sedation, and then we place it. You can see how the bone bulges. Now, the reason we want minimum flap, we want to keep the periosteum, because what you're going to do is you're going to create microfractures. So when it's all finished, we put in they were 3 O's, and now the abutments on 3 O's, you torque at 15. Everything else is 35. So we have a nice result. So there's just some example. You can see the size of the flap on the left, just as small, just so we can look at that crustal bone and see where we are. And these are just another examples. Whether we use a titanium or ceramic abutment, we should be able to have something similar, especially if you use the experienced people at Glidewell. So what about insufficient volume? Play it safe. We graft, we can go back and 5-6 months later. This is my treatment coordinator who's been with me for 46 years. Apparently this tooth was fractured, but she didn't know it till it became looser. So it's probably walking around with it for a year like that. So there's a lot of bone loss. So these are the things I use. The particulate is in a syringe. Again, all this is I get from Glidewell. The suture is Vicro. I've been using it for years. It's clean. Plaque doesn't stick to it. It's great. I use 3O of this suture and the Osteogen plug. So also, I'm a big fan of kits rather than the assistants chasing instruments around. So again, this is available from Glidewell. So we have what I call a bone grafting kit. Gives you the instruments, at least my favorites for the grafts. So here we're putting in the particulate and then covering over with the putty. And then we did like a 4-point closure. So 5 months later, I actually just did this like a month ago. When after 5 months, I went in, just used a tissue punch. We had a nice wide ridge, placed a 4.3 by 13. You can see the bone we harvest in the drills. So this is another example of insufficient volume. This was a fractured tooth, lose a lot of buccal bone. You can see the amount of graft we put in. And then after 6 months, we went in, you can see the try-in just starting, so we can check to see if this is real bone. And it was, so we put the implant in, 3-millimeter healing abutment. And then 4 months later, we did the restoration. You can see the gum is pink and stippled, so we know it's healthy. And if you look, it's integrated. So we all have these kind of teeth in your practice. Molars, root canal, multiple roots. And you take them out in pieces. Now again, I'm going to graft because we want to use a nice wide implant, a little bit longer, because again, we're talking 4 times vertical load in the posterior. So we do a 4-point closure. This is just acts like to confine the graft. And so what happens here is in about 48 hours, it starts to granulate over the tissue. But to try to make a flap to cover this all, you would have to make a very, very aggressive flap. So we know this works. So here it is. Took it out, graft. 4 to 5 months later, placed a nice, longer, wider implant. And then we harvest some bone, got some human histology at 13 weeks, and we can see that there is bone. So nice, wide implant. And then the lab again provided Buxer crown. Now today, I did this a number of years ago. I would do screw retained. Now this patient came as a result, again, from the website, immediate placement. But I was the 4th dentist. She came in and I said, well, what about ortho? She said, you're the 4th one to tell me that. If you don't do it, somebody will do it. And I thought, well, maybe this would be interesting. So we took it out and I knew she had actually too much buccal bone for gingival harmony. So I'm going to reshape this, this buccal ridge, recontour it. So it's going to be more in harmony with the adjacent teeth. So this is number 7. And so it's in harmony with 6 and 8 when it's finally finished. So what about implant failure? We talk about all the successes. So it's generally going to be loose. So you take it out, remove any soft tissue or granulation tissue. If all the socket walls are there, then you might be able to self-tap the next size, next diameter implant. If the walls aren't intact, then graft and place another implant 5 or 6 months later. Okay, the patient may be disappointed, but as long as you take care of it, they're not going to be mad. Do not place another implant or graft in active infection. We talked about that before. So Albert Einstein says, failure is success in progress. It's only failure if you give up. So through my years, if we had a lot of trial and error, there wasn't a lot of experienced people before us. So if we learned something, in other words, we did something and it failed, then failure repeated itself. We did the same thing again on somebody else. Same with success. So success repeated itself. So if you did something, you knew it was bad to start with, that's a failure. If you learned something from it, that's success. So what are the causes for failure? Well, my number 1 is occlusion. And the other, of course, to start with, insufficient volume of bone to start with. But we're not going to place that implant if that's the case. So occlusion, and then if we're doing multiple implant replacements, it's not enough implants for the desired prosthesis. So this is my pilot's checklist for multiple cases. What is the desired prosthesis? What is the quality of bone? Is it in the posterior maxilla, softer bone, or anterior mandible, which has good bone? Which is the posing dentition? Is it natural teeth, bridge work, or fixed? Or is it a denture? How strong is the musculature? How strong is that patient? So there's a patient that has strong musculature. It's an upper case against natural teeth, so 8 implants. So here's Mike here. He had hopeless upper and lower, which you'll see in the X-ray before we started. But you see that one spot, it looks like it's number 8 area. You can see where I went to the palatal with the first twist drill. Now, the reason we keep this so close to the palatal wall has to do with the prosthesis, because we're going to do screw retain hybrid, and we don't want those screw accesses come through the buccal. So we want to, again, when you pick up that 2 millimeter twist drill, I'm thinking prosthetics. So here we see, you see the X-ray, what was going on with Mike. He had strong musculature though. So you see the multi-unit abutments, the transfers. I again use closed tray. We use old school alloy wax bite and refine that bite with a vanilla wash, vanilla material, splash, whatever. Anyhow, I mark the midline, then send that all to the lab. Then the lab will give me back a wax try-in, which will try, chances are it's off, but we want to make sure it fits. So chances are the occlusion's off, may not be perfect aesthetic, there may be some openings at the margin. So we want to correct all that, take a new bite, and then send that to the lab. Now the lab will send reaffirmation where it shows where the screw accesses are going to be, so it's not through the buccal. So then the lab will send back what we call PMMAs. That isn't what these are. These are the finals. So we can put those in and let the patient test drive it for 3 weeks and then address any issues. If the bite needs adjusted again, any openings, we can fix that before it gets into the bruxer. Because once it gets into the bruxer, it's really difficult to fix. That material is so hard and so good, but aesthetically, you can't beat it. So we have 2 aesthetic bruxer hybrids. So what have I learned through the years? Well, don't save compromised teeth. You're not doing the patient any favor. Patients are happy especially root canal teeth, they have a propensity to break. And they're very grateful if you can take that tooth out and give them an implant with a temporary. They walk out of your office like that. They talk about it. That's marketing. Okay, know how much bone volume is available. Treatment plan for the desired prosthesis. Avoid overloading, not enough implants, and occlusion. Avoid tightening the implant over 50 newtons so you don't cause compression. Compression will cause bone loss. Avoid placing implants too close to one another so we have space for bone and blood supply. Keep implants away from contacting the buccal or facial bone at the time of placement. Do screw retain restorations when possible. Again, it's easier to maintain if you have to do something. Select patients that have a positive attitude. Use an experienced, high-quality laboratory. And this patient said, exact quote, "I couldn't be happier." So you see that everything I touch goes to Glidewell because their technicians that we work with are the most experienced, and they know what we need, what we want, and how to help us and guide us. So you see the cases in progress and also cases that have been finished. I call them the dead soldiers. This is just one floor of Glidewell. I couldn't even get it all in one picture. So if you come to the symposium, they will take you on a tour and you'll get to see something that's really amazing. So again, the best way to predict the future is to create it. And that's what I've tried to do. This is Abraham Lincoln's quote. I'm granted the patent for the tapered implant in 93. I conceived the idea in 1993, but these things don't go that fast. But anyhow, as you know, since then, most companies have copied that. As Neil mentioned, Dr. Park mentioned, I received the Isaiah Liu Memorial Research Award, and that has to do with your contribution that you did to implant dentistry. And my idea, because I've taught general dentistry for over 30 years, general dentist, implant, basic, predictable, safe, predictable, successful, profitable implant dentistry, is to make it easier for more people, more dentists to be able to treat their patients with problems of edentulosum or what we see as the single tooth immediate. So Roger Levine once said that the future is so bright we have to wear sunglasses. So it is, the future is bright. I know what's coming down the line and it's going to be exciting. So those of you that are getting involved are very lucky. Here's my contact information. So
Jack, I'm going to jump in because we've got some questions we want to answer, but I really do think it is important to point out that you are one of a handful of doctors who made implant dentistry safe for all of us now, right? You know, we're only doing this on a day-to-day basis because what you and that handful of other pioneers did. And I think, you know, getting the lecture from you and looking at the historical perspective and the perspective that you have, I think it's incredibly valuable. So I'm gonna start taking some questions. There were some great questions here. That was a great lecture. I mean, you covered that topic so beautifully. You really did. So the first question was, you talked a little bit about the design of the Hahn implant, and I had a question about straight versus tapered implants. And first of all, why a tapered implant? And I know you could talk forever on this, but just a couple of things.
The very first picture I showed was really the solution for anterior loss of a tooth. And how I conceived it was, if you get your implant glasses on, the patients come in, you'll see like schools of fish. One day you'll see more than one case that's exactly the same as the previous one. So one day I had 4 single tooth different patients to do replacements. And I was using the Stereos parallel walled implant. And in order to prevent from penetrating the subnasal fossa, I found myself tilting these implants in a labial direction, which made it more difficult to restore. And so I wouldn't penetrate the subnasal fossa. So that evening, I'm thinking to myself, if the tooth came out at a tapered root, why am I putting in a square implant in a tapered hole? So I'm thinking about this. About 1 a.m, I jump out of bed. My wife says, "What's the matter? What's the matter?" I said, "Nothing." So I went in and drew an implant with a tapered root on a piece of
Yeah.
paper.
I mean,
So
there's so many good
that's,
reasons. Anatomically, you can avoid certain
yeah,
areas of anatomy that you want to avoid. You can get a bigger implant in than if you used a straight implant of the same diameter.
yeah,
But
that's exactly right.
one of our listeners asked a really interesting question. Are there any specific situations where you would prefer a straight implant to a tapered implant?
No, most of the people that use parallel wall implants, and when they switched over and started doing taper, they said to me, "Once you do taper, you won't go back." And
And
so,
Jack, you probably remember you and I had a meeting with Carl Misch where we presented the tapered implant to him, and I can't repeat what he said, but basically he had a very hilarious explanation of how he switched from a straight implant to a tapered implant. So
yeah,
it was very
he
interesting.
said it's your fault.
Yeah, well, it was even funnier than that. So now another question here about grafting. At what size of a gap, you've placed the implant and there's a gap between the implant and the socket wall. How big does that
More,
gap have to be before you would place
more,
grafting material?
more than 2 millimeters.
Okay.
Uh, so if you have like 3, uh, if it's 2 or less, the blood will take care of that. The blood will act like a graft, actually. A very well-known periodontist in Arizona. He was a big proponent of just uh, starting and talking about that, about when you use graft material or not. And it's real simple. You don't need to flap. You can just tuck some of that hydrate, the particulate cortical cancellous, and just tuck it under there. And then you're not making a flap. You're just loosening the edges of the tissue. So when you tighten a suture mesial distal, you're basically purse stringing it. So you're providing like a seal. And this works. Uh,
Okay, Jack, as far as the atraumatic extraction, you mentioned this 700 XXL burr that you use.
yeah.
And then you also mentioned a tapered elevator. Do you remember the name or
Oh, there's a
manufacturer of
lot
that?
of companies. Salvin has this in their catalog. There's a lot of companies that have these. I don't use periotomes because they're too flimsy, but there's a small, there's 2 instruments um, in that beveled elevator. There's a small one, which is for like laterals, real small, mesial distal width of it, and then that's a larger one. So if you get the Salvin, there's probably other companies that have it, but Salvin, so I get it from. And I also get the 700 XXLs from them.
Okay. And you talked about you have your own nomenclature for different sockets. And I remember type 1 was an intact socket, and type 3 was a socket that has is missing a facial or buccal wall. What was the type 2 socket? I didn't remember that, and somebody asked.
The top 2 had a hole. It could either be at the apex or halfway up the root. We see a number of those, and but the crestal bone was intact, and there was a little bit of bone apical, so that you prepare it just as if that hole wasn't there. And then I put the hydrated particulate, and then as you put the implant in, it squeezes the graft material through the window like a porthole.
Yeah, that's a neat technique. And you mentioned that you like to use putty. You say you don't really use membranes very much, but you like to use putty. What is the putty that you use? I had a question about that.
It's an osteogen plug. Uh, it has the cortical cancellous particles mixed into it and collagen, and it works real nice. Uh, and the nice thing about it is you can mold it, and when blood uh, comes around it, uh, it stays in place. In membranes, you get one part of it tucked in, the other part comes out. It's like putting a 10-legged cat in a bag. So this stays, it's easier to work with, and it's predictable. It has not let me down.
Excellent, excellent. Now here a doctor has kind of presented a treatment that he's suggesting. So if you extract the tooth and you notice granulation tissue periapically, he's suggesting that you curettage, irrigate with saline, and then place a restin prior to implant placement along with the bone graft. Do you find that to be necessary? Like, will you go ahead and place the implant sometimes if there's granulation tissue at the apex?
Well, we clean it. When you clean it, when you think you got it clean, clean some more, because that granulation tissue wants to stick. But no, I don't do that. I go ahead, prepare the site and place the implant. Because
Exactly. Like so the
there,
fact that there's some apical infection is not a contraindication for immediate placement by any stretch.
if it's not active, if it's just chronic, if you, let's say the patient comes in and you know that uh, there's a problem, there's infection, then place the patient on antibiotics and then go back a week to 10 days later and do your procedure. And you can just clean it good, because what you've done, you've taken an acute situation and made it chronic. So if it's just chronic granulation tissue, just straight granulation tissue, no purulence,
How
just
about a
clean it.
fistula?
With purulent fistula, I know there are people that will clean it and go on with the process. I found that it's safer to let it clean it good, put the patient on antibiotics 10 days to 2 weeks, and then go back and do it. Because if it's active, the pH will eat your graft material up.
Okay. When you're doing adjacent immediate placement implants, are you concerned about compressing the bone between the roots? I noticed one of the things you said was never place them too close together. Um, like how much space can you have before you
Yeah,
start worrying about
yeah,
compressing that bone between them?
yeah, yeah. Some of these congested laterals, you're very constricted as far as that goes. Now, you saw a couple when I did the bone expansion that were real close to the adjacent teeth. Now, the rule of thumb is to be 2 millimeters, but in those cases, you're not going to be. The main thing is you don't infringe on the cortical plate, on the cribiform plate that's around the root, which has the periodontal ligament also with it. So what I do is go in with the first drill, maybe 8 millimeters, and then take an x-ray, like you're doing an endo, and then see your direction. Now, I didn't mention what happens if you hit the adjacent tooth with your drill. In other words, you're drilling, and then all of a sudden, what'll happen is it'll jerk your handpiece. It's called handpiece chatter. So the minute that happens, you stop, put a guide pin in, and take an x-ray. Again, then you can redirect it. Now, you're not, and it's not going to hurt that tooth. What'll happen is it'll get some bleeding, and then it'll regenerate. You're not going to go all the way through, because fortunate enough, those 2 millimeter twist drills are beveled, so they only cut on the very end. So when you go up and hit that, that means the side of it's hit, and that's why the handpiece starts to rattle a little bit.
Got it. Got it.
So you just take your time. So some of those were very, very close, but we did not infringe on the lamina propria.
Yeah, I've seen you thread the
There's
needle quite a few times. Some of them can be close. Um, Jack, there's a lot of courses and talk about using PRF. Do you use any of that material for soft tissue management?
No, I'll tell you what's nice about the osteoplug. And I put any of the bone grafting material, you've got to put it against blood. You've got to have bleeding. If you don't have bleeding, we may take a burr and punch some holes to get some bleeding. So that's one thing. And then adding the material with the collagen over it, the soft tissue is beautiful. You saw that one bicuspid lower where it just had the transfer in that real tight pink tissue. Yeah, it just works. Now doing the PRP, I'm not against it. Plastic surgeons use it a lot. That involves drawing the patient's blood, spinning it down, this and that. I try to keep it simple, be able to teach to have more people to do it practically, and not have any kinds of risks.
And you've had a lot of years of clinical success not using it, so I think I think that speaks for itself. I'm going to finish with a question here that we really haven't approached, but I think it would be helpful to our attendees today. Talking about fees, you don't have to specifically say a number, but like this emergency treatment that you do, which is such a valuable service, how does that compare to what you would charge for an implant that had in the healed site that patient had an appointment? Can you talk a little bit of guidance here on fees?
Yeah, well, I'm in an area, Cincinnati is not like Beverly Hills. Most of the patients are working people, so money is a factor. It's probably the biggest factor that we find. So I try to make it affordable. So it's not that much more than a 3-unit bridge. I'll just tell you, the extraction, the temporary abutment, and the final ceramic restoration is anywhere from 48 to 5,200, and that's it. That includes everything. And the same goes with our full arch cases. Our biggest competitor is Clear Choice, and they're 7,000 to 10,000 an arch higher. And because again, the people with terminal teeth situations generally don't have a lot of funds. They haven't put $1 a day under their pillow to save for teeth. So we have to make it so more people can do it. And I was able to probably do as many full arch cases as a single practitioner than them. They actually told somebody in Cincinnati that I was their biggest competitor, but I don't think that's true.
Well, Jack, it's always a pleasure to talk to you. Today is absolutely no exception, and I'm going to look forward to seeing you at the Implant Surgical Symposium in a couple of weeks. We're looking forward to having you up there on the main podium, and so thank you for this great lecture, and thanks everyone for joining us today. And thanks to our panel, which once again had great advice. And we're going to see everybody back next week when we'll have, as always, our business advisory panel. And our guest speaker will be Dr. Christopher Resnick. And he's going to be talking about surgical guides for more complex cases. And this includes those multi-level or stackable guides, so you can have fully guided bone reduction, implant placement. It's even guided abutment placement, and the pickup of your immediate provisional is all guided. So he's going to show some really neat cases. So don't miss that one. And we'll see you back next week. Take care, everybody, and hope you have a great week. Bye-bye. Thanks, Jack.